there's no need to cancel many patients. But we're still very careful with admitting and treating patients where we expect that they will be on ICU for many weeks. Thank you very much.
Thank you very much, Alexander, for this nice presentation. I can see there were differences between countries. We will see them after. If you have any questions, please type them into your boxes. And now it's my honor to introduce the next speaker, Dr. Alessandro Brunelli. He's a consultant thoracic surgeon and honorary clinical associate professor at the Department of Thoracic Surgery at the St. James University Hospital in Leeds, United Kingdom. He was former vice director of the Division of Thoracic Surgery and head of section of minimally invasive thoracic surgery in Ancona, Italy, where he worked for more than 15 years. He is President-elect and Secretary-General of our, let's say so, sister society, one of the sister societies of the EACTA, the European Society of Thoracic Surgeons, ESTS. Moreover, he is leading the European Institutional Accreditation Program, and his main professional and scientific interests focus on minimally invasive thoracic surgery, quality of care, risk stratification, and modeling, and patient outcomes and health economics. So he will talk on returning to elective thoracic surgery in a dedicated COVID-19 hospital, how, when, and for which patients. Please, Alessandro.
Thank you very much, and thank you to the organizing committee, to EACTA, to involve me in this webinar. I don't have any conflict relevant to this presentation to disclose. So I want to put my talk in the context of what is happening now in UK. These slides are somewhat a week old now, but we have more or less 2,000 cases now a day, still a day of COVID tested positive patients, and approximately 280,000 patients so far have been confirmed in UK. We have a daily death rate of about 200 patients still, and the total death toll, unfortunately, here in UK is the highest in Europe, and the second highest in the world is 40,000 people, unfortunately. This slide is very important because it shows the pressure, the current pressure to hospitals, and in particular to ICU. At the moment, we have less than 9% of ICU beds occupied by COVID-positive patients. Many of the new ICU pods and the new hospitals, field hospitals created here in UK, were really underutilized or not used at all. Obviously it is time now, after this couple of months of restriction, to gradually return to elective surgery, to increase our activity, our normal, let's say, activity. And the Royal College of Surgeons has published this checklist for all the hospitals in England to verify whether they are in a position to resume elective activity. First of all, it is important that they will show a sustained reduction in the trend of COVID positive cases, and especially in the admission to ICU, to have capacity in their hospital. Obviously, there must be availability of PPE for all the staff, and testing for patients and staff. the wards and the theaters, should dedicated to elective activity should be kept COVID cold. So there must be a segregation of activity when returning to elective surgery. And obviously there must be availability of staff and resources. There have been some recommendations and guidelines during the peak of this pandemic and the most critical period. This is one of the that I found most useful because it combines the availability of resources, alternative treatment, and severity of surgery, and it is the one proposed by the American College of Surgeons. If we compare the current phase, the resumption phase, we can compare it to, the preparation phase or the semi-urgent setting where when few COVID patients were present in the hospital and the hospital resources were not completely exhausted. And obviously ICU beds were still available. So at that time, the American College of Surgeons for thoracic surgery, for lung surgery or esophageal surgery recommended to go ahead with cancer surgery, not benign cases, obviously, especially for cancer at risk of rapid progression, like those with positive lymph node or those with symptoms. And the BTS published similar guidelines. They never changed this. There are no updated guidance at the moment, but this is still current. Obviously, cancer that are risk of progression, local progression, should be not deferred. Perhaps we could defer patients with slowly growing lesion, and for whom there are no valid alternative treatment. A problem we had here in UK was that chemotherapy was stopped at some point in the form of three-modality treatment, so neoadjuvant or adjuvant chemotherapy before or after cancer operation was stopped, and now is gradually resuming. We now have, to be honest, a different problem